Welcome to this explainer. Okay, today we are handing you a completely reliable, foolproof mathematical toolkit. If you're a healthcare student learning clinical dosage calculations or a clinician stepping onto the pediatric ward, getting this right isn't just a nice skill to have. It's absolutely essential for patient safety. By the end of our time together, you'll have a super simple, step-by-step guide to determine safe medication dosages and prevent potentially life-threatening pediatric medication errors. So let's jump right in. Children are not small adults. I know, it sounds incredibly obvious, right? But this one simple phrase actually anchors literally everything we do in pediatric pharmacotherapy. You absolutely cannot just take an adult dose of a medication and shrink it down linearly based on a kid's size. If you do that, you are risking catastrophic toxicity, or on the flip side, complete therapeutic failure. And this leads us to a pretty sobering reality. Dosing errors in pediatrics are a leading cause of preventable patient harm. Because a child's body processes drugs completely differently than an adult, your margin for error is razor thin. So as the clinician, you are the absolute final safeguard, standing between a simple math mistake and serious patient harm. Here's our agenda for today. First, we'll cover why children aren't just small adults. Then, math foundations, focusing on ratios and conversions. After that, mastering weight-based dosing. Then we'll level up to calculating body surface area. And finally, we'll wrap up with clinical safety and error prevention. All right, starting off with Section 1. Children are not small adults. We are talking about extreme pharmacokinetic variability here. Think about it. Your patient population spans from a tiny premature neonate all the way up to a fully developed 16-year-old adolescent. Across that entire spectrum, kids have immature organ systems, completely different body water percentages, and they go through these massive, rapid growth phases. Plus, their clearing organs like the kidneys and liver, they mature non-linearly. All of this means highly individualized dosage adjustments are an absolute must. Okay, moving right along to Section 2, math foundations, ratios, and conversions. These right here are your universal truths. You absolutely must standardize your units using these exact conversions. Guessing or estimating a child's weight or height is just incredibly dangerous. If a parent tells you their kid is 44 pounds and 40 inches tall, you have to convert that. So 44 pounds becomes exactly 20 kilograms. 40 inches becomes roughly 101.6 centimeters. And for volume, a standard teaspoon is exactly 5 milliliters. Just lock these into your memory. Now, I really want to emphasize the single most critical, error-prone conversion in all of pediatrics, 2.2. You must divide a patient's weight in pounds by this exact number to get their weight in kilograms. Never multiply. Always divide pounds by 2.2. Honestly, forgetting this step is a classic clinical trap, and you definitely don't want to fall into it. All right, let's talk about the universally applicable ratio and proportion framework. If you are a student, this is your absolute best friend. It's the core mathematical process behind almost all common pharmacy calculations. Basically, if you know a certain amount of drug is in a specific volume of liquid, you use this comparative relationship to find out exactly how much liquid you need for your specific patient's dose. When you break it down into these 4 sequential steps, you can confidently figure out the exact milligrams or milliliters you need without any cognitive overload. Let's say you have 160 milligrams in 5 milliliters, and you need to give a 240 milligram dose. You just set up your ratio, cross-multiply 240 by 5, divide by 160, and boom, you arrive perfectly at 7.5 milliliters. It's simple, it's reliable, and most importantly, it's safe. Let's transition over to Section 3, mastering weight-based dosing. This formula right here is your frontline tool. The vast majority of pediatric medications, think your daily antibiotics, analgesics like ibuprofen, and antipyretics for fevers, they all rely on this. It gives you a customized approach that's tailored perfectly to the child's exact mass. Always follow this specific walkthrough. Step 1, convert pounds to kilograms. Step 2, multiply that kilogram weight by the prescribed dose. And step 3, this is absolutely vital. Verify the calculated dose against your safe dose range, which you'll usually find in a pediatric formulary. I can't stress this enough. Making absolutely sure you never skip that first step of converting to kilograms will save you from accidentally giving double the required medication. Which brings us to the golden rule. No matter what your math says, you strictly cap the dose at the adult maximum. With rising pediatric obesity rates, a weight-based calculation for a heavier child might give you a dose of, say, 2,500 milligrams. But if the absolute adult maximum for that specific drug is 2,000 milligrams, you stop at 2,000. No exceptions.
Okay, Section 4, Calculating Body Surface Area.
So, you might be wondering, if weight-based dosing is so great, why do we even need body surface area, or BSA? Well, body weight alone doesn't account for things like metabolic demand, extracellular fluid volume, and cardiac output. So, for highly complex biotherapeutics or high-toxicity oncology drugs that have a very narrow therapeutic index, BSA is the preferred, much more precise clinical standard.
And this perfectly illustrates why we use the equations we do today. Let's compare two major formulas. The historical Du Bois formula from 1916 uses incredibly complex mathematical exponents, and get this, it was derived from a tiny sample of just 9 subjects over a century ago. It's famously inaccurate for kids under 10 kilograms. Now contrast that with Mosteller's formula from 1987. It uses a simple square root, and it's been widely validated across both adults and children. Mosteller's simplicity is exactly why it's the modern student-friendly default.
The Mosteller formula is just so elegant. First, you convert the child's height to centimeters and their weight to kilograms. Multiply those together, divide that number by 3,600, and then just find the square root. That result is your body surface area in square meters. From there, you simply multiply the BSA by the prescribed dose per square meter. Easy, right?
And finally, Section 5, Clinical Safety and Error Prevention.
Here is a bulletproof 6-step action plan developed specifically for clinical practice. Extract the data, standardize your units, verify safety ranges, calculate the dose, apply a common sense test, and execute a final verification. And check out those NCLEX traps on the side, things like forgetting to convert pounds to kilograms or messing up IV flow rates. If you follow this standardized template, you basically eliminate those cognitive errors. The Institute for Safe Medication Practices actually mandates these specific systemic safeguards to protect vulnerable pediatric patients. We have to mandate kilogram-only scales, so nobody accidentally logs a weight in pounds. We use milliliter-only liquid dosing, so definitely no more household teaspoons. And this is absolutely critical. Always use leading zeros like 0.5 milligrams, but never, ever use trailing zeros like 5.0 milligrams, because if someone misses that decimal point, 5.0 suddenly becomes a fatal 50 milligram overdose. As you step into clinical practice, you have to remember that a tiny fraction of a decimal point can literally be a matter of life and death. The math is just a tool, but your critical thinking, that's the real intervention. Always ask yourself, does this volume actually make sense for a baby? Will your calculations pass the common sense test? Always double check your math, trust your ratios, and advocate for your patients. Thanks so much for joining me on this explainer, and stay focused out there.